supraglottic cancer. Over the past few years, what we are seeing is a change in the statistics. We are starting to see more of glottic cancers because of the way the society is progressing. More of smoked tobacco is being used over the earlier chewed tobacco, the smokeless form. So along the way, we are going to see more of early cancers. We're going to have a huge cadre of doctors who are going to diagnose this early. And it is incumbent on us to actually understand how we can use endolaryngeal approaches for surgical voice preservation. When you look at endolaryngeal surgery, it is a minimal access surgery and it has a proven oncologic safety. You can do voice preservation and you can avoid a tracheostomy. And this is key in preserving the quality of life of the patient. Now, when would you actually offer this to the patient? Whenever you have got a good access to the laryngopharynx. This is critical in our country, especially when patients have trismus and poor dentition. Cervical problems and a normal hyomandibular complex are essential to give you a good access to the endolarynx. Now, for the youngsters in the audience, a good method of assessing whether you can actually go ahead and do this is from this paper by Piazza from Brescia, when they looked at 11 parameters. And it makes common sense for us to understand that if your mouth opening is adequate, if you have got good dental status, if you have got a normal mandible, you will be able to actually position your laryngoscope very well and reach in and clear your disease completely. If on the other hand, these parameters are affected, you'll find it hard to even expose the endolarynx. The various devices, laryngoscopes, which are available, which can increase your access. And we need to have this armamentarium with us in order to improve our access. Various modalities that I'm going to talk to you today about are the transoral laser microsurgery and the transoral video laryngoscopic surgery. These are cost-effective solutions which most institutions would have today, and we will get access to these lesions from within. Now, the transoral laser microsurgery has got at least 4 decades of use, and over the past few decades, we have refined the technology. Today, you have the scanner technology, which actually allows you to use higher wattage and do a very fine resection without transferring the heat to the contralateral tissue. The transoral video endoscopic surgery is a more recent development in the past decade. It uses devices such as the FK retractor, which has got various blades which give you a very good access into the base tongue, the larynx, and the hypopharynx. The traditional way was to use a descending laryngoscope, but this device gives you a better ability to visualize and do a resection from within. The surgical instruments used for this are usually the routinely available instruments in your general operating theater. You would have the forceps, the scissors, the hook scalpels, and the needle scalpels. Now, when we are doing endolaryngeal surgery, our focus should be on the oncologic safety first and voice preservation next. The cases that are amenable for this are carcinoma in situ to T1 and T2 lesions, all of which have normal chord mobility. Early supraglottic lesions such as this are a rarity, but if you get such a lesion, this is amenable to an endolaryngeal resection. Likewise, if you get lesions such as this, which are limited in its extent, you can resect these hypopharyngeal cancers transorally. How do you go about it? The most important criteria is to understand how you're going to resect it and what structures you're going to resect it. The European Laryngology Society has divided and classified these into various types, from type 1, which is a subepithelial chordectomy, the type 2, which is a subligamental chordectomy. Type 3 onwards, it becomes resection of the muscle and various structures such as the arytenoid, false chord, and the subglottis. The type 6 chordectomy is the one wherein the anterior commissure is resected. Now, the type 1 chordectomy is the one which allows you to remove only the mucosa and preserve the entire muscle along with its ligament. So typically you will see a lesion like this, which will then rise with your submucosal infiltration and allow you the ability to resect only the mucosa. You can see this is a microspot laser which we used a couple of years ago. And with this, we are able to delineate the entire lesion and go submucosal. And then, like what was practiced earlier, what was called as a stripping of the vocal cord. And this is a controlled resection of the mucosa of this tissue, which slides over the ligament, as you can see here. After the resection, you would clean it properly with a wet cotton patty, and you'll get a resection which will have a complete mucosalization and preservation of normal voice. A lesion which goes beyond the ligament. Now you have got the scanner technology, which allows you to resect with as little carbonization as possible. As you can see here, the scanner allows you to modulate the laser in a very controlled fashion. And as you can see, there is no charring, and you are able to resect with a much more wattage of energy, achieving good hemostasis, but at the same time avoiding any charring. In this case is a type 2 chordectomy, wherein the mucosa as well as the ligament is resected. You can see how the ability to change position of the laser beam allows you to resect only the parts that you have, control your depth of resection, and preserve as much normal muscle as you can see. You can see you're going right between the ligament and the muscle and resect the entire lesion with a good margin. At the end of this procedure, you would have a normal vocal cord preserved without much of charring and thermal damage. So this is a lesion, this is a post-op video showing how the vocal cord heals. And I can challenge anybody to tell me which side of this patient was resected. Further down, when you're doing extended resections, as Steiner described it as a segmental sequential resection, you would then remove it in two parts. The anterior part is usually removed first so that you get more space. Sorry, the posterior part is removed first so that you get more space to visualize the anterior part. So once you have resected, cut the lesion, transected it, and seen the depth, you can then proceed to resect the posterior half with a good margin, and then go on to remove the anterior half. This was an extended chordectomy. You can see how the lesion was amenable to a complete resection with a subpericondyal resection. This was an extended type 5 chordectomy. Not all require such increased depth of resection, and some are extended but remain submucosal in its extent. So this was a type 5 chordectomy where the entire cord was resected with the anterior 1/3, but it was only a mucosal resection. So this was an extended chordectomy, but you can see that this patient has absolutely normal voice. So what are the outcomes following tonsil laser resection? In T1 glottic cancers, you have local control rates of 91%. And today what we are focusing on is how many of these will have a preserved larynx. And almost 98% of them would have a preserved larynx. With inner T2 glottic cancer, most series give you control rates upwards of 80% and a larynx preservation rate of around 70 to 85%. This systematic review and meta-analysis of a T1 glottic cancer comparing carbon dioxide laser to radiotherapy clearly shows that there is a favor treatment for transoral laser microsurgery in terms of the disease-specific survival, the overall survival, as well as laryngeal preservation. There is no difference in local control in between transoral laser and radiation therapy. Coming to T3 laryngeal cancers, there are a subset of these which are amenable, and these series from the Steiner group shows that you can have a local control rates of around 71.4%. Even in the T4 laryngeal cancers, you see that if you apply the transoral laser surgery, you can have local control rates of around 67%, which are similar to what is achieved with concurrent chemoradiation. Coming to supraglottic cancers, lesions such as this are amenable to a transoral laser resection. Tumors which are coming on from the lingual surface of the epiglottis and have both cords mobile. These are eminently resectable, and a patient who has got good lung function and has normal vocal cord mobility. In these patients, a complete resection of this lesion will ensure that the patient has a good laryngeal swallow, good airway, and good phonation. A similar kind of a laser resection is done with the tumor being removed R block. You don't need to remove R block like in Steiner technique. You can remove this in two segments and resect it with a good margin all around. The only concern here is bleeding, and care has to be taken to have your suction coagulators and your clip applicators in order to achieve a good hemostasis. At the end of the procedure, you would have resected the entire tumor along with parts of the pre-epiglottic space, achieved good hemostasis, and resect the lesion completely. At the end of the procedure, you would have a picture like this, wherein you would have very little thermal damage, and this part's being healed, which will heal very well with good voice. What are the outcomes following supraglottic cancer resection? The 5-year local control rates of T1, T2 are around, T1 cancers are 500%, and T2 cancers around 89% from the world series of Steiners. In pyriform sinus cancers as well, in stages 1 and 2, the 5-year overall survival rates are around 71%. Coming to transoral video endoscopic surgery, these are suitable in supraglottic cancers and in hypopharyngeal cancers. A typical lesion would be a hypopharyngeal cancer, which is limited in its reach to one side of the pyriform sinus. In this case, which was shared by Professor Akihiro Shiryotani from Japan, this patient had a very early superficial lesion of the postcricoid, and this was amenable to a transoral resection. So you can see that the lesion was almost reaching the postcricoid, and in this case, this complete resection was done with electrocautery. You can see the endoscope, which is a semi-rigid endoscope, allows you good visualization of the lesion all around, which is similar to a robotic surgery today. This will give you a good access, good control using electrocautery devices, and a complete resection with margins. We need to endeavor to do these because these are using equipments which are readily available in any surgical practice, and you can use the endoscope to get a good visualization. The complete preservation of the postcricoid musculature and the innervation, as well as a complete resection with good margins. A good orientation is important following the resection. You can use hemostatic tissue glue around this and put a Ryle's tube so that the patient can have good swallow function. And this is at the end of 3 months, 8 weeks. And this is the normal swallow. So this is the outcome that we should expect when you have early glottic and early hypopharyngeal cancer with transoral resection. We also have done supraglottic resections and hypopharyngeal cancers with this, and we were able to achieve a good hemostasis along with the electrocautery devices, which are a worry when you're using a transoral laser resection. A complete resection of this supraglottic disease was possible. This was in the lingual surface of the epiglottis. You can see how a complete resection of the vallecula with exposure of the hyoid and complete resection of the vallecula along with the epiglottis was possible with the help of the transoral video endoscopic surgery. Regular instrumentation, bipolar devices, and the electrocautery allow this resection with very good control. You can see the hyoid bone here, and you can see the innervation, the nerves coming through at the thyroid membrane. The video endoscope gives you a good access with an angle vision, which is sometimes not possible with the help of microscope. So what are the outcomes with transoral video endoscopic surgery? When you look at hypopharynx and supraglottis, when you look at the T1 to T4, all stages, the median follow-up of 5 years, the 5-year overall survival is around 83%. And the larynx preservation rate is around 94%. Even in supraglottic cancers, you have larynx preservation rate upwards of 90% in T1, T2, and 100% in stages 3 and 4. Of course, these are very limited diseases and in selective group of patients. So at the end, I would like to leave you with some messages. The transoral laser or video laryngoscopic surgery is a cost-effective solution. It gives you good illumination and magnification. Patient side positioning and tactile feedback are distinct advantages over robotic surgery. Oncologic safety is good, and larynx and voice preservation rates are good. With experience and training of supportive staff and use of novel instrumentation, endolaryngeal surgery is the future in resource-constrained environments such as ours. Thank you for a very patient listening, and I will be happy to answer any questions.
Elaborate space to space, even size to size, you just elaborate in those spaces. I think this is not very clear. But still, I would like to have a comment from Dr. Pudol Nazarika, who is a very senior surgeon, to give some comment on this presentation and if there is any. Dr. Nazarika, sir.
Sir.
From the side. Why you are a chairman? I'm the chairman. I want to.
Sorry, I'm not able to hear you.
You have some comment on this presentation and would
Sir.
like to say a few words.
Sir, can you come here?
Please come.
Please come. Actually, this operation is fine.
Can someone repeat the message, a question, please?
Please, hypopharyngeal cancer.
Oh, this is the laryngeal cancer, right?
Yeah.
We want to go back to hypopharyngeal cancer.
Yes.
What I had a lot of experience with the laryngeal cancer. I am very happy to treat the laryngeal cancer. The results are very, very good. At the same time, hypopharyngeal cancer results, in my time, 5 years with radical surgery, radiations and all, it was 5 years survival, something like between, something not beyond 60%. So it was very bad. In spite of now I have seen what endoscopically is showing a better
That's what
result.
I'm asking.
But-
to have
but
a comment
again-
on.
But again, there are so many other factors also depends, immunological factors are not coming up very high way. It is only not the surgery, chemo and radiation is the only answer for that. I have seen name care. I came back, one of my brother's friend. He had a early malignancy, right pipe from fossa, and he was suggested for surgery here. We got scared. We went to Apollo. So they asked me this, but they can X-ray. They saw a small spot in the cyst. Well, then I say, don't undergo surgery, go for chemo radio. He has undergone that, then came back after 5 years, no, 5 months or so, there's a recurrence. Then it has undergone surgical procedure, there's a gland also. So after 5 months, again, he had a recurrence. We have seen him here. Then went back again. They give the chemo. He's doing very well now. He's swallowing and swelling, disappear. Neck becomes soft and all these things. So the I don't know, the surgery and chemo and radiation is not the proper answer for the hyperpharyngeal malignancy. You have to look into the immunotherapy also. And present, I think immunotherapy coming in a very, very big way. And
Mostly
yeah,
advanced cases.
hopefully-
So it is early.
Yeah. And they're claiming very good result. Even the Boston, somebody one, they treated on some guy, he presented himself that he is cancer-free now. So the only one I'm worried about hyperpharyngeal malignancy, rest of the things are not must be worried about. And this again, the endolaryngal surgery is coming up a big way. I don't know. It can be done, resection with all gadget and all, taking it out, but morbidity have to think about. And whether this particular surgery is feasible to do it here, I do not know. But surgery is much easier endoscopically with all diaphragms and all laser. I used to do KTP 532
I
laser.
think it's all thing about early diagnosis, finding the lesions in an early stage. You have an infrastructure where you can do these lasers, surgeries, take effective, and then leave the patient a quality of life with voice.
Yes.
The question here is life with voice. Otherwise, earlier we used to remove the larynx and then give life only. Now it's life with voice.
Yeah.
So it's
So
very
that is
good.
not-
Thank you very
No,
much.
that
for
is
the-
awareness. As you say, the early diagnosis is the best.
Yes, that's right.
If you can do it, cancer
Side by
cure.
side, you have to
Yeah.
have the facility for
Yes,
handling
yes,
these
yeah.
early cases. That's
So-
very important.
So the awareness by the Vibura Institute,
Thank you very
that
much.
is very good. Okay, thank you.
Dr. Hazarika. One question is, there is a question I heard you can ask Dr. Pai.
Professor Pai, there are a few questions from the audience.
Not able to hear it very clearly, please.
Is it clear? My voice is clear now?
Yes, please.
There is a question, yeah. There is a question from Dr. S.B. Fukan, Guwahati, a senior ENT surgeon from Guwahati. You must be knowing him. And Dr. S.B. Fukan, he is asking one question. Is there any scope of frozen section in endolaryngeal surgery from the margin of the tumor?
So for early glottic cancers, the margins required are between 1 to 2 millimeters. So what we advise is to take those 1 to 2 millimeter margins and resect, because it is very difficult for processing very tiny bits of tissue in frozen section. So yes, there is a role of frozen section, and especially in lesions like the extended cordectomy, which I showed, wherein you would have to remove the lesion in segments. In those cases wherein you are worried about the third dimension, the mucosa is not the worry. The worry is in the third dimension towards the muscle. And in those cases, it would be prudent in order to take a frozen section control. There have been reports which have shown that if you have a positive margin, there are more likelihood that the patient will fail and lose the larynx. In those cases, it would have been wiser if you had resected, if you had a positive margin. And remember, in any soft tissue, such as a muscle, it is very difficult to understand where is the positive margin. So at the time of surgery itself, if you feel that you are close, you should resect adequately on the third dimension. If you have already done a transmuscular resection, it's not that you're going to improve the voice quality much more by preserving a few millimeters. So if you are doing a type 1 or a type 2 cordectomy, it is sufficient to take adequate mucosal margin. If you are doing a transmuscular or extended resections, go wide and resect it adequately the first time round. If you have the ability to have a frozen section control, it is good in these third dimensions. I hope I am very clear.
Thank you. Thank you.
very much. Thank you. I hand over the mic to Dr. Sarma. Please take to the next slide.
And thank you, Surya sir. Thank you, Professor Pai, for your excellent talk, and everybody enjoyed this informative talk. Thank you very much.
Thank you very much.
Our next speaker will be Dr. Anil De Cruz, who is the president of UICC, and he will be talking about the head and neck cancer. And for this session, I would like to request Dr. S.B. Phukon and Dr. D.K. Nath, senior consultants of Guwahati, to share that session. Dr. Anil De Cruz.
Good evening, everybody. Should I speak or would our chairpersons like to make some comments before I start? Hello?
Hello. Hello.
Yeah, am I heard? Audible?
Yeah, you're nice. I'm Dr. S.B. Phukon. I thank the organizer of this hospital for giving me opportunity to share a session of a legend person with head and neck surgery. And not only he is the president of the UICC, but he was the past president of the FHNO and the director of the Tata Memorial Cancer Institute. And I think those who have gone through the lecture, I think his voice and his presence always be remembered. Now I request you, sir, to start your talk, delivery.
Good evening. Thank you for that very, very kind introduction. Before I start, am I clearly audible to everybody listening?
Sir.
Yeah. Okay. So thank you to the organizers, Professor Quddus Ahmed, for giving me this chance on a very important day, the World Head and Neck Day, to deliberate and share my thoughts on head and neck cancer in India. And Quddus said that you focus on challenges rather than treatment. Since I exited Tata's 3 years back, I wear two hats. I wore two hats then as well, one as a treating clinician and the second as a director. But now I wear two hats, one heading the Union International for Cancer Control, which is the largest NGO globally based in Geneva, representing 172 countries committed to the cause of cancer control. And the second is I continue to treat, teach, and research on head and neck cancer. And today I'm going to share with you perspectives of the challenges that I have seen with these two hats on, both as a clinician over the years and now looking at it in a global perspective, heading the UICC, where our aim is to control cancer and make cancer care equitable, that is available to all. We know that head and neck is our problem. It's a problem in Asia. Here are Globocan data showing that 50% of all head and neck cancers occur in our part of the world. In our country, it is 25 to 30% of all cancers, as opposed to the West, where it is 4 to 5% of Western cancers. 50% of the oral cancers globally occur in our part of the world. Here is recent data from population-based cancer registry program, as well as hospital-based cancer registries, 28 population-based registries, 58 hospital-based registries, 4-year data, looking at a huge number of patients, showing that there would be a projected increase. But I want you to focus on the last bullet. Out of the 5 leading sites in our country, 2 are from the head and neck, just telling us how important this cancer is to our country. And that's predominantly because of tobacco consumption. It's socially accepted. It's part of our culture in the country. You can see it's everywhere, the hoardings all over our country, on our trains, on our buses. Young people take to the habit in the mistaken belief that it's good for the teeth. Here is a lady from rural Maharashtra applying a burnt tobacco to a tooth. And these little kiosks or pawn shops are seen all over our country. And this photograph is taken between 2 chemists on the street opposite the Tata Memorial Hospital, just magnifying why it is socially accepted. And it's a big challenge in our country, and that's why we see so many head and neck cancers. Government has done a lot. Tobacco advertising is banned on electronic media. We have heavy taxation. Smoking is banned in public places. Gutka has been banned in 18 states in our country. Yet 266.8 million Indians, that is 42.4% of our countrymen, consume tobacco. If you look at children between 13 and 15, it's close to 20% that consume tobacco. And even those who do not consume above the age of 15 are exposed to secondhand smoke. So the biggest challenge that we face is tobacco control. Now, WHO, looking at the various aspects of tobacco control, that is clean air, offer cessation treatments, warning on packages, marketing bans, and raising taxes, find that raising taxes is the single most important maneuver that will get people to use less tobacco. I showed you government initiatives, and those are heavy taxation on cigarettes. So the cigarette consumption in our country is showing a downward trend. But that much taxation is not on chewed tobacco products and on the bidi, which the majority of our countrymen use. And that's why we have this big problem of tobacco. And it's my urgent plea to people listening who are in positions of power and can influence government to raise taxes on the low-cost products in our country. And Prabhat Jha, in his landmark NEJM publication, showed that 50% increase in inflation-adjusted tobacco prices reduces consumption by about 20% in both high-income and low and middle-income countries. So we must increase taxes on our low-cost products. And the biggest challenge we face because of this increased incidence is because of not proper targeted approach to decreasing tobacco consumption in our country. The second challenge that we face is seeing the T6 tumors. I call them T6 because they're way beyond T4. And I'm sure all of y'all see 60 to 80% of your patients like this. 2/3 of our patients are locally advanced at presentation. There's a problem with early diagnosis. And this is a paradox because head and neck cancers have a known etiological factor in tobacco. We have a well-defined progression model. We have definite pre-malignant lesions, and we have easy accessibility. So there is something that we can do to get these cancers at an early. And we have compelling data from our country in screening. The Kerala randomized trial, 1 lakh patients, health education and visual examination. The other 1 lakh just health education. There was no demonstrable difference in the mortality of cancer in the 2 arms when you looked at the entire population. But when you looked at the subset of patients who used tobacco and alcohol, there was a 0.33% reduction in mortality. And that is compelling data that we must have screening programs to help in early detection. Unfortunately, we don't have the budget to have screening programs, but here is the Kerala study, a rehash of the entire data, looking at what they caused a risk-based selection of individuals for oral cancer screening. You had to screen 2,043 patients, individuals, not patients, their population, to prevent one death across the entire population. But if you looked at high risk screening group, you just needed half the number of patients, 1,029, to prevent one death. And if you looked among those who had heavy tobacco and alcohol consumption, we only needed to screen 610 individuals across 50% of individuals at the highest risk of using tobacco and alcohol. So we must have a risk-based selection approach to screening patients. We can't screen a 1.3 billion Indians for oral cancer, but we could target high-risk screening. And we wrote a lovely review in Nature's, Dr. Richa and myself, where we reviewed literature, reviewed the Kerala trial, and showed that in resource-constrained settings, high-risk screening is very, very important. It's not only in resource-constrained settings, even in high-income settings where head and neck is not a priority, they can't screen everybody for head and neck. So again, there they could look at high-risk screening. And in times such as these of COVID, where we don't want many people to come and open their mouth in front of us, we can just focus on the high-risk group and get our patients at an early stage. The third challenge that we face is inequalities in treatment facilities. Here's a morphed cartoon of the entire globe. If you see areas which have the highest population, that is panel A, and you can see India looking nice and pregnant, India and China and this part, you have the highest burden of disease as well in these parts of the world. We still seem to have a little blue, less than the dark blue of Africa. But for head and neck, definitely this is as high or higher than Africa. We have the least number of medical schools, and we have a shrinking workforce. All this adding to inequalities in treatment facilities. Now, government is doing a lot. We have the National Cancer Institute in Delhi, the Department of Atomic Energy, 6 new hospitals. BB Barua is also one of them that has been taken over. We have new aims like institutions. The private sector is expanding. Apollo, for example, where I work, is the first to get the proton into the country, which should have been the other way around. Tata should have got it much before a private sector, but yes, private sector is contributing. And we've had an exponential increase in the number of postgraduate positions. And congratulations to BB Barua now that has post-graduation within the portals of that great institution. But there's a lot to be done on the workforce. We have increasing institutions, but we must also focus on quality of the products that come out from these institutions. The fourth challenge that we have is subsidy in treatment. Now we have general treatments. Now BB Barua will have 60% of the patients that are general. Tata Memorial have 60% of patients that are general. All India have nearly 80-90% that are general. General means subsidized, government pays for these patients. Now, this is a paradox. We subsidize treatment, but how good it is, we don't know. Now, when I was at Tata's, I did this study with 116 patients who had oral cancer. 62 of our patients were subsidized and 54 were private patients, non-subsidized. And we estimated direct costs and indirect costs, and we did a cost-based analysis model. Direct costs is what they paid to the hospital, medicine, stay, bed charges, nursing charges. Indirect costs were when they left their home, their tickets, staying in a lodge, buying food for the family, and we looked at both direct and indirect costs. The subsidized or general class patients spend less on direct costs, but 2 to 3 times more on indirect costs because of long waiting. So sometimes it's better for a person to opt for semi-private treatment than general treatment because the indirect costs are more. The unsubsidized group spend 2 to 3 times more on the direct costs. But those that were subsidized had bigger non-compliance to adjuvant treatment. So we treat patients in general ward, we operate them, they don't take radiotherapy subsequently, dropout is much more. As a result, you have wasted expenditure subsidizing their surgical treatment because there's a higher incidence of recurrence of these patients. The fifth problem that we face is high mortality. If you look at the incidence to mortality ratio in our country, it's 0.69. That means for every 3 patients diagnosed, 2 die. Compare it to the West where it's 0.33. That means there 2 are saved, 1 die. Now we know that late presentation, socio-economic factors are important. But the other factor is non-compliance to evidence-based treatment. Here is ICMR data looking at oral cancers being treated. And this is old data, but it still drives the point home. In Mumbai, the majority got surgery. But when you go down to Chennai, Trivandrum, the majority go for radiotherapy first. And this kind of practice still continues for a long, long time. We know that oral cancers is a surgical disease. So if you don't adhere to evidence-based guidelines, you're going to have an increased mortality. And here again is a study I did when I was at Tata's, looking at nearly 1,500 patients divided between Tata's and 37.2% who got treatment elsewhere. You can see that the place of treatment significantly associated with adherence across all stages of treatment. So those that got treated outside had less evidence-based practice than those that were treated in Tata Memorial Hospital. And the reason for deviation were more physician and treatment centers in the community compared to tertiary cancer care centers. So we have to make a strong pledge that our patients be treated with evidence-based guidelines. The seventh problem, palliative care. An estimated 40 million people annually are in need of palliative care worldwide. 78% of these live in our parts of the world. Yet only 14% of people who need palliative care receive it. So we have a problem among our patients who recur. We are not able to treat them. They can't afford the palliative chemotherapy. There are a lot of problems, and that is a huge challenge for us. The last challenge is research. We have barriers for conducting clinical research in our country. Another study that I did with another bright fellow of mine, Dr. Mitali, and I only want you all to focus on the last bullet which I've underlined. More than half the respondents of this survey, it was a questionnaire-based survey, without experience in clinical trials, worked in academic institutions, 50.48%, and they perceive time constraints as barriers to do research. Now, this is important because we are treating patients, and only if you do research, you'll have better outcomes and you'll be able to do cost-effective measures. And I think we need to do research to find cost-effective innovations to care. Prathamesh in his talk said that it is important to do laser in resource constrained. I am not sure how a resource constrained institution can afford a 1 crore laser, can afford the consumables, can afford the FK retractor and that whole range of retractors that he showed in resource constraints. That is for the high risk or the high developed countries. It cannot be for resource constrained patients. We need to do cost effective innovations. Do the Babatron, which should have been developed more. It's a cost effective indigenous radiotherapy, 75% shortage of radiotherapy machines. Do good protocols. 6 days versus 5 days radiotherapy. You'll treat patients faster, get more people on machines. Metronomic chemotherapy that we started when I was in Tata's, and now the medical oncology team has taken forward a beautiful way to replace immunotherapy in our patients. I'm going to end with this slide. We need a diagonal approach to healthcare. Our government, our leaders are only making new institutions, getting the high-tech equipment and increasing the number of postgraduate seats. That's called vertical approach. It will treat patients, but you will not have the best outcome. However swanky your hospital is, if a patient comes in stage 4, head and neck, you will only be able to cure 40% of your patients. A horizontal approach of prevention and early diagnosis is important, but the long-term effects will be seen of this approach. If we start the horizontal approach of improving public care systems, public health systems, we'll only see the rewards after 10 to 15 years. What we need is a diagonal approach, a combination of vertical to horizontal. And whenever you see any of our leaders speaking, even when they come to BB Barua, they will all talk about buying new equipment, putting new proton centers, opening 20 new hospitals. Very few of them will talk about what they're doing in the field, how they have improved, like say mass vaccination of HPV in our country, oral cancer screening, breast self-examination. And I think we need a combination of both in the diagonal approach to face the 8 challenges that I have shared with you, that we as clinicians and global public health experts face in the management of cancers, and in this case, head and neck cancers in specific. So thanks once again on this important day, a World Head and Neck Day, to speak to you all, share my thoughts about prevention, share my thoughts about screening, share my thoughts about other challenges that I have witnessed. And I feel if we address, we will be able to help our patients more. I come into Guwahati now quite often, once a month at least, renew bonds with y'all guys, and hopefully I'll get a chance to speak to some of y'all, meet y'all. And I told Ashok and Tasleem and others, when I come, I'd love to come to BB Barua, do a clinic, teach the youngsters. And if y'all have time, I'll be happy to do that on my next visit. Thank you once again. My coordinates are on this thank you slide.
Professor Deepu sir, I'm Dr. D.K. Nathia. Sir, thank you for your very excellent talk, very outstanding talk. We have learned a lot from you. As a UICC president of Geneva, you have given some very good data. So we are really thankful to you, and we are really privileged to hear you today's evening. So now I request to put forward one comment from Kudus Ahmed sir. And 2 questions only will be allowed because we are running behind the schedule.
Hello. Can you hear me, Anand?
Yeah, very well, Kudus.
So thanks so much for being with us this evening. It was really good to hear from you. There are just a couple of questions that you might be able to take before we close this session. Any questions?
Hello. I want
Hello,
to ask a question because you mentioned about Kerala, one study.
Yes.
It is said Kerala has the highest incidence, first to Mizoram. And but Bihari people are taking more gurkha and khani. Why they are less sufferer in cancer than the Keralites?
I didn't get that. You said Kerala has a.
Highest incidence of head and neck cancer.
No, they don't have the highest incidence. The highest incidence is in other Northeast and all is very high. Kerala is also high. The screening study was done in Kerala
Yes.
and they looked at high risk screening. So among 1 lakh population, the people who consumed tobacco and alcohol were at the highest risk and they had an excess mortality. So if you focus your screening programs, I didn't say they have a higher risk. Parts of Assam have a very high incidence of tobacco-related cancers. Northeast has a very high incidence. UP and Eastern UP, MP, Bihar have a high incidence. So it is not that, it is just that it is the high risk people in Kerala that benefited from the screening.
Sir, you have mentioned metronomic therapy regarding cost-effective treatment. So what is your experience regarding metronomic therapy? Can you share with us?
So when we were at Tata's, because out of compulsion, we had to give metronomic chemotherapy. It was a 3-drug regime where we gave methotrexate, erlotinib, and we gave celecoxib. In this combination, it did have some effect on some of our patients. Earlier, before this regime came, we used to give single dose Geftinib, but that didn't prove to be good because there was a randomized trial showing that it was not as good as conventional treatment. For want of giving anything else, we do give metronomic chemotherapy. But now, this ASCO, Kumar Prabhash and group from Tata's did publish giving low dose nivolumab, which is an immunotherapy, 20 milligrams every 3 weeks, which is like 1/5 the dose that we normally give. It brings down the cost, and they showed that the PD-L1 receptors could be saturated with this low dose. They show exciting results, but I am not sure these results are as good as the prescribed regimes for palliative. But where I use it is when we have a patient who has disease which is asymptomatic. Suddenly in your first follow-up, second follow-up, fourth follow-up, patient comes. You do an imaging and you find a PET uptake in the lungs. Patient is asymptomatic. I start metronomic chemotherapy to keep it under check. It's a couple of 100 rupees, no side effects. Patient can take the tablets at home and I give them this regime. The moment the tumor grows and the patient has symptoms, I would change on to something that has a higher response rate.
Thank you, sir.
Thank you.
Thank you very much, sir, for your excellent deliberation. You are always a good modulator of voice and everything. I think if there's no any comment from the.
So thank you once again for having me. Thank you for your kind words. I'll miss the fellowship, but maybe I'll do it virtually here in Mumbai while you all do it after the program in Guwahati.
Thank you, sir. Thank you very much.
Thank you.
Sir. And we are really thankful to you for your love for the Northeast. You are coming to Northeast periodically. And I will request our junior and senior colleagues to take the opportunity to have the consultation with Kush sir. Thank you, Professor Kush sir.
Thank you.
So nice of you. Thank you
Bye.
very much.
Bye. Bye.
God bless you.
Bye.